Today we are going to talk about the stroke. So what are all the occupational therapy management in the stroke? We are all occupational therapists, so we are going to focus on the occupational therapy. Okay, we all know stroke, clinically known as cerebrovascular accident. Why it is happen? It is due to the lack of blood supply to the brain. Why the lack of blood supply? It is because of two reasons. One is ischemia, another one is hemorrhage. Ischemia is a blood clots obstruct the blood flow. In hemorrhage, there is a leaking or bleeding into the brain tissue leads to the lack of blood supply to the one area. Okay. What are the common impairment? Also occupational therapy, we have to looking in some impairment only. First, hemiplegia. The person having the weakness or paralysis of the one side of the body, including the face. Okay. So the person may experience aphasia, which means they can't even speak normally. Okay. It comes to the brain, right? So in brain we have the motor, sensory, and language like that, and also we have the cognition. So attention, memory, and executive function. So these areas are going to affected in the stroke patients. So in this area, person may have in the impairment. So these include induce the person can't able to the problem occurs. So generally in stroke patient in these areas the problem going to occur. First motor, then sensory, then brain cognition, then vision and perception. Cognition, perception is you know. Then obviously affect their radial and also their psychosocial, which means emotion, radial and emotion. They have the overall problem, so the communication may affect and how their environment is there. So we have to assess excessively how their environment now. Is there any safety in their home? Anything is accessible to him. So they are wheelchair, right? So they have to access everything they need. So that environmental assessment and upper limb function, how their upper limb is functioning. So like that we are going to focus. Motor in many areas like range of motion, strength, muscle strength, and coordination. In sensory, we first focus on the tactile, okay, tactile sensation, then proprioception, then stereognosis. In cognition, we already said right, attention, memory, and problem solving. In vision, we are focusing on the visual field. In perception, neglect and the depth perception. In ADL, we are focusing on everything, feeding, dressing, grooming, hygiene, etc. What are the areas? Money management, everything. In psychosocial, is the person having any depression, motivation, any frustration? So like that we have to assess. In communication, they are expressing how they are receiving the communication. Is there any verbal or non-verbal? So like that we have to analyze. So when the stroke patient is come, these components should be analyzed by us. Okay, not only by the assessment tools, by also our observation. Okay, let's discuss about the assessment tools for the motor. Starting with manual muscle test, that is for the muscle strength. Then range of motion, which is assessed by the goniometer. We all know range of motion. Okay. Then Mayer assessment. Then Bothell index, which means ADL is also assessed by the Bothell index and FIM. Okay, functional independence measure and modified Rankin scale. Then cognitive and perceptual assessment tools. It include Lowenstein OT cognitive assessment, Montreal cognitive assessment, visual assessment matrix. These are all used for the cognitive perceptual. Then we are focusing on the ADL. In this ADL, Canadian Occupational Performance Measure, and we can also use the Bothell index and FIM and assessment of the motor and process skills. Then we have to look upon the sensory. For that, we may use the semi-Weinstein monofilament test. Okay, these are all the assessment tools used by the occupational therapist to assess that areas. Okay, then we are focusing on the goals after assessing. So these are all the problems the person may have. Then we have to focus on the goal. So we have to set the goal first, then focus on the goal, and we have to start the intervention. Okay, starting with the goals. It is divided into two goals: short-term goals and long-term goals. Short-term goals can be achieved by 3 months. Long-term goals could be achieved within 1 year. Okay, so that like that we have to set the goals. Short-term goals, it include the improvement in sitting balance. So first of all, we have to focus on the sitting balance, right? The person can't even able to make the correct posture and correct sitting. So we have to focus on that first. Then we have to minimize the assistant during grooming. So the person going to groom everywhere. Okay. So for that, the person need assistant first. So we have to reduce the assistant, and we have to increase the range of motion. Okay, then in long-term goals, we have to improve the participation of the person in their meaningful life role. So in this, we are going to make them participate in their life role, including their own ideal and their own transfer, including their own occasions, their own work, their own everything. So we are going to improve the goals to their life roles. Then comes to the occupational therapy tools and techniques. In this, we are going to use some techniques. Okay, analyze the stroke patients are forgot their what they are doing before, like that their body forget everything. So we have to rehabilitate, which means their habits should be restored. So for that, we are going to use some techniques and tools. These are all for the fine motor skill development. So the person may forget their fine motor skills, like holding like that. So we have to improve the fine motor skills, and also we have to improve the majorly in neurological cases we don't use the fine motor skills. We have to use the hand function. Okay, in my slide I just forgot everything and I typed. Okay, you have to follow that. Okay, then alongside adaptive utensils, we all know for communication for their daily activities we have to have the utensils like handled brush. For dressing we have to the utensils. So these are all may rehabilitate their life. Okay, okay, then mobility and facilitate the controlled movement of the person, and also use some orthotic devices and splints. So splints may maintaining the proper alignment and it prevent the contracture, and they are supporting the weak limbs. Okay, and for the hemiplegia person, their limbs are weak. For that, that devices are used. Then proper positioning, we all know splints are more common for maintaining the position, and it also prevent the secondary complications. Then come to the specialized therapies. In occupational therapy, we use some specialized therapy like mirror box therapy. Imagine your one hand is only functioning. In mirror, you see this hand is functioning. Then what your brain thinks is your both hands are functioning. Like that, your brain thinks, and it also induces some recovery stages. So this like specialized therapy we are using in the occupational therapy. Okay, then also task-oriented kits like a dressing board, grooming set, like that we are going to use. And the sensory integration materials we are also using. Okay, OT approaches in stroke rehabilitation. What are the approaches we are using? Let's discuss one by one. Okay, starting with biomechanical. So we all know the person having the low muscle strength and the range of motion is reduced. Like that, in biomechanical approach, we are using the approach to improve the strength, endurance, range of motion. Okay, for that we are using exercise, splinting, and positioning. We are using then rehabilitative approach. In this, we are going to use compensation techniques and adaptive techniques and remediation techniques. So the goal of this approach is to rehabilitate the person, which means what are the tasks done earlier that should be done by them. Okay, for that we may use the compensatory techniques. If they eat in right hand, we can make them eat in left hand, or we can give the spoons. So that like that compensatory techniques and adaptations, and also use of assistive devices. So these are all used in the rehabilitative approach. Then neurodevelopmental therapy. It also focus on which is much more important in the stroke. Okay, so the person may have the abnormal reflex. Okay, so for that we have to use that normal movement patterns. Okay, we are going to normalize the muscle tone in this neurodevelopmental treatment, and also we are going to inhibit the abnormal reflex, and also we are going to facilitate the normal movement of the person. Okay, so in this we have some handling techniques. Okay, and then roots approach. We all know the person having the muscle tone problem and the motor response problem. So for that we are going to use the sensory stimulation like brushing, icing, tapping for the facilitation or inhibition. Their muscle tone may be increased or decreased. For that we have to facilitate the muscle tone or inhibit the muscle tone. Their motor patterns are also used in the roots approach. Then motor relearning program. It focuses on the relearning the moment. So how they are learn by their task. So we're going to give the task. That task should make them relearn their old movements. Okay, so that is a relearning program. It should be practice. So motor relearning program is mainly focused on the practice. So practice makes everything perfect. That is the main of the motor relearning program. Then constraint induced movement, which means we all know one hand is unaffected, one hand is only affected. if this unaffected hand is not there, so if it is absent, completely absent, then we have to use only the affected limb. So that is a constraint induced movement therapy, which means they restrict their affected limb movement. It induces the affected limb movement, and the person have to survive with their only affected limb. So that also induces their brain movements, and it also improve the recovery. Then task oriented approach. So this is goal oriented. So their functional activities should be measured, and for that we have to receive tasks. So according to the person, we have to do the task that improve their skills, their lacking skills. That is a task oriented approach. Okay. By using this approach, we are going to rehabilitate the person. In rehabilitation, we have to minimize the assistance of the person and increase the independence of the person. Okay. So they should come to the community again. Okay. First, starting with the early stage, we are dividing the intervention process into three stages. In first stage, we should prevent the complication. What are the major complications? They are bedridden, right? So they may have the bed sores. We have to prevent the bed sores, and they may have chances to get the contracture because their hands are in same position. So for that, we have to focus on the contracture and the bed sores. So for this, we have to focus on proper positioning in bed and wheelchair. And also for the contracture, we have to focus on the passive and active range of motion exercises. Okay. Along with that, in early stage, we have to educate the family. Okay. And also we have to focus on the safety of the patient. Okay. In middle stage, we are going to focus on the ADL of the person, such as grooming and dressing. Not only that, every ADL activities of daily living should be engaged actively by the person, okay, affected person. So the upper limb is much more important for our daily task, right? So here in middle stage, we have to focus on that. Alongside, we have to focus on the functional mobility, like transfers, starting with upper limb. Okay, so ADL should be noticed as well as starting with upper limb. Then we have to focus on the functional mobility, which means we are going to use the lower limb, starting with the transfer, bed to wheelchair, then assisted walking. So wheelchair walking, assisted walking, and normal walking. So we have to gradually neglect body neglect may be acquired. So we have to modify them by using the interventions. Then late stages. In late stage, we have to make the person re-enter into the community. So it includes the vocational training. They are working. So the person may work in any area. So we have to modify the working area according to the person and making them enabled to work. Vocational retraining should be given, and advanced cognitive rehabilitation, which means we are going to rehabilitate their thinking, memory, attention, everything. Okay, area, which means the person emotions. Okay, which is much more important in recovery, and also it is long term also. Okay, educate family. So the family members should accept the person. Okay, so for that we have to educate the person, and awareness about the stroke should be teach to the person and the caregiver. So that is a education. Okay, so it supports the patient effectively. Then come to the emotional needs. So in emotional needs, when we looking the depression, anxiety, and frustration, so it may happen in a patient as well as caregiver. We have to focus on both. So we have to give counseling to the both, and support groups. We have to refer to the support groups. Other groups are there. Okay, so that group members should encourage the person. Then empower the patient and the caregiver, which is much more important because the caregiver may sometimes lack some skills, right? Sometimes lack confidence. We have to empower them. Then we have to making them handling the patient. So caregiver is empowered, then the patient is empowered. Okay. So we have to focus on the work modification. What are the home modification we can do? Toilet training. In, for instead of stairs, we can use the slides. So like that, we have to focus. In environmental modifications, we may use any sensory integrative areas, their pressure areas. So like that, we have to focus. So these are all going to rehabilitate the stroke patient in occupational therapy area. So not only this, we can use many creative ideas to treat the stroke patients. So this is a general anonymous stroke patients. Generally, we are focusing on these areas only. So most of the cases are going to having a problem in these areas. So like that, I give the lectures. Okay. So another one I want to say, we don't use the fine and gross motor skills in the neuro. we have to use hand functions. Okay, in this video we are just discussed about the stroke and the OT management. In next videos we are going to discuss about many other conditions and the OT management. Okay guys, thanks for watching. Please subscribe to our channel. Keep watching. We are going to upload many more topics related to the OT. Thanks.